presence as usual. And hopefully, in the span of ilan na meetings na lang tayo, we make them memorable, and we get. I hope we get something from our discussions. So. Okay, so for tonight, I'll be discussing um, acute kidney injury, which is a sequelae or one of the sequelae of our previous discussion, which is sepsis or septic shock. AKI is a important, I think, have you discussed, tapos na kayo sa renal? Sorry, pharmacotherapeutics, ay, hindi, 4, I think, yung may renal diseases. Tama ba? If I'm not mistaken. Tama po ba? Tapos na po kayo sa pharmacotherapeutics ng renal?
Yes, Doc.
Tapos na, okay. So you have the idea of what is AKI, no? Discuss niyo ba yung AKI? Or siguro CKD or whichever. Pero I'll be more focusing on the pharmacist perspective, no? Kasi for sure you've discussed na AKI in general, meaning general in terms of medical definition and medical understanding. But we'll be focusing more on how do we view AKI as a pharmacist, and how do we interpret, and how does it really matters to us pharmacists, lalo na when we're working or when we are practicing na the clinical pharmacy practice. Okay. For the learning objectives of this topic, will be identifying the brief pathophysiology of AKI since the discussion and before. Ito yung importante, the differentiation between AKI and CKD. And we will be distinguish among the different types of AKI and identify some drug-induced causes, which is our main role dito. And we'll also be familiarizing ourselves with the different diagnostics using AKI. And of course, we'll be discussing the management of AKI. In definition, siguro sa iba, you can see some other references that uses acute renal failure compared with AKI. Pero kasi ngayon, mas appropriate na yung term ng AKI. And usually, it results in abrupt loss of kidney function within 48 hours. That's why it's acute kidney injury. There can be structural damage. That's why magkakaroon tayo ng rise in serum creatinine and with or without reduced urine output depending on the severity and phase of AKI ng pasyente. And here are the main causes or main manifestation of AKI. We have pre-renal azothemia. We also have post-renal obstruction and intrinsic or parenchymal AKI, or which is the true AKI dito sa ating topic, tinatawag. Again, it's an abrupt loss of kidney function leading to retention of waste products, which is the main role of our kidneys in the body, regular physiology. Retention of waste products, will be also having some electrolyte disturbances and also some volume status change. Yes, no? Meaning there will be a presence of congestion. And many patients with AKI have a mixed etiology. So that's why sabi ko, it can be a sequelae of sepsis. In the presence of sepsis, pwedeng magka-AKI. In the presence of ischemia also, pwede rin magkaroon ng AKI and nephrotoxicity. And they often coexist and complicate recognition and treatment. Of course, the main biomarker that that is used in the diagnosis of AKI is serum creatinine. But it is termed as an imperfect biomarker for recognizing AKI. No? Kasi sometimes it does not. It depends on the case of the patient. As we've discussed previously, for patients who are malnourished, yung merong mga muscle wasting na condition, no? Hindi ganun ka-applicable yung applicable or ganun ka-reliable ang serum creatinine for them since they have limited muscle mass. That's why it's an imperfect biomarker for recognizing AKI. And usually in AKI, there will be an increase in serum creatinine often fall behind the onset of injury. So magkakaroon usually between 48 to 72 hours, no? Ganun kabilis ang rise of serum creatinine. For the diagnostic parameters, of course, acute decrease in GFR or creatinine clearance as reflected by an acute rise in serum creatinine levels and or decline in urine output over a given time interval. Yun ang tatlong main coverage or tatlong main um, symptoms and main that describes an AKI. Okay, increased rise in serum creatinine, a decrease in GFR or creatinine clearance, and a decline in urine output over a given time interval. There are different types of parameters that are used in the practice. You have the rifle criteria, you have the Akin, and the KDIGO. There are differences. These are some guide in which they help us identify if the patient is on AKI or is experiencing AKI. Ayan lang yung example naman, no need to, I'm just showing you there are different types of criteria. But the main, um, or yung common in the three of them is that, as I've mentioned a while ago, increase in serum creatinine, a decline in um, GFR or creatinine clearance, and a decline also in the urine output. Yun lang ang tinitignan din doon. Pero dito, nakalagay na kasi para ma-recognize lang yung mga different stages of AKI. Okay? Okay. In this slide, I will just like to emphasize the most common etiology of AKI in the hospital is septic shock, which accounts to 47.5% of overall hospital, and the overall hospital mortality was 60%. Okay? Ganun din sinasabi nun. Okay, we go to the risk factors. Age, of course, rise as the patient age, they are more at risk in AKI because of the presence of comorbidity, no? Like CKD, DM, hypertension, CAD, CHF, COPD, and liver diseases. Proteinuria as well, of course, when protein pass into the tubules of the kidney, meaning there's something wrong with the glomerular filtration. Nephrotoxic exposures like contrast dye for patients who have undergone CT scan with contrast, and of course some nephrotoxic drugs, major surgery as well, sepsis, fluid resuscitation. See, hydroxyethyl starch has been associated with an increased risk of AKI compared with crystalloid solutions like PNSS and PLRS, and volume status as well of the patient. Okay, so we'll be focusing here. Ito lang ang main cause or main etiology and the pathophysiology of AKI. We have pre-renal, intrinsic, and post-renal. Pre-renal meaning meron decrease in renal perfusion in the setting of undamaged parenchymal tissue, meaning there are no direct damage to the kidney. Meaning it can be a ischemia, no? Hindi directly in the kidney na tamaan. Can be a decrease in renal perfusion due to ischemia. Intrinsic, dito naman, ito ang tinatawag na true AKI. It is because it will result in a structural damage to the kidney itself, damaged parenchymal tissue, damaged tubules, and most commonly in the tubule from an ischemic or toxic insult directly into the tubule of the kidneys. Post-renal, post meaning right after the kidneys, doon focused or doon naman resulting from an obstruction of urine flow downstream from the kidney. Pwedeng kidney stones sa ureters that can cause acute kidney injury. Okay? Pre-renal. When we say pre-renal AKI, Meron through volume, the causes, one common cause is through volume depletion. Paano ba nagkakaroon ng volume depletion sa isang pasyente? Diarrhea, vomiting, GI disturbances or other hemorrhage na nagde-deplete ng blood volume or fluid in our body. CHF as well, because there will be a reduced cardiac output. A reduced cardiac output can decrease renal perfusion, which may cause or contribute to the development of pre-renal AKI, hepatic cirrhosis as well because of peripheral vasodilation and arteriovenous shunting. Nephrotic syndrome. I think you've already discussed nephrotic and nephritic syndrome. No? May difference sila. And severe hypoproteinemia. Renovascular disease as well because of fixed stenosis at the level of the main artery or large blood vessels. So, pinapakita lang dyan na in a pre-renal AKI, there are no direct damage to the renal cells or the nephrons. The main damage is from these conditions. Post-renal, as we've said a while ago, pwedeng obstruction, bladder outlet obstruction, pwedeng merong BPH yung pasyente, benign prostatic hyperplasia, malignancy, presence of tumor, the use of anticholinergic drugs, no? Which causes urinary retention, displaced bladder catheter. Sa urethral obstruction naman, again, malignancy, meron din nephrolithiasis or kidney stones, and also with renal pelvis tubular obstruction. And drugs also, yung mga drugs na excreted extensively in renal in the urine, no, like sulfonamides and acyclovir. Okay, for intrinsic, again, it represents true kidney disease kasi it has a direct destruction doon na mismo sa loob ng kidneys. Kasi si pre-renal and post-renal are consequences of extrarenal diseases na tinatawag. Okay? Which causes a decrease or fall in GFR. If this persists, okay? If this persists in pre-renal and post-renal, they will eventually evolve to renal cellular damage and hence, intrinsic renal disease na sila or intrinsic AKI. Okay? That's the difference. For intrinsic AKI naman, it's a direct damage to the nephrons. The problem is in the kidney itself. No? There will be a difficulty into filtering blood, removal of waste, excessive H2 water, excessive water can cause congestion sa ating mga pasyente and maintain electrolyte levels as well. Difficulty in maintaining electrolyte levels. So, dito ang 4 major sites of renal parenchymal damage sa mga tubules, glomeruli, into the interstitium, intrarenal blood vessels as well. For tubular, the main cause is nephrotoxins. It can be endogenous if meron presence of rhabdomyolysis and hemolysis of the cells. Okay? Exogenous can be from contrast dye and some drugs like cisplatin, aminoglycoside gentamicin, and amphotericin B. So meaning, we all know aminoglycosides, amphotericin B are nephrotoxic drugs. Pinapakita lang dito, saan siya nephrotoxic? In the tubules of the kidney. Doon nagmamanifest yung nephrotoxic effect niya. Ischemia as well. Ischemia, pwede rin shock and hemorrhage and sepsis. No? Endogenous naman, myeloma proteins, uric acid in the presence of tumor lysis syndrome, some cellular debris. Exogenous naman, ayan, kasama din ng mga drugs like acyclovir and methotrexate. Interstitial, in the interstitial or the interstitium, medications na NSAID, rifampicin, phenytoin, and the others. Infection, presence of severe pyelonephritis, Legionella, Streptococcus, sepsis, infiltration like lymphoma and leukemia, so malignancy pa din, and inflammation in the tubulointerstitial nephritis and uveitis in the kidney. Yung say vascular vessels, dito na pumapasok. Pag vessels, ang causes are usually from vasculitis. and glomerulonephritis, no? And others follows na lang. Pero ang main cause dito sa vascular and or vessels na intrinsic AKI, specifically in the vascular vessels, is caused by some glomerulonephritis and vasculitis, inflammation. TTP, DIC, or also if meron siyang atheroemboli, malignant hypertension, sepsis. Sa mga large vessels naman, renal artery embolus, renal vein thrombosis, and if meron abdominal compartment syndrome. Okay, so dami nun, no? So we'll be now focusing on the difference of an intrinsic and a post-renal AKI. Okay? Intrinsic or intrarenal AKI, meaning again, direct damage to the nephrons, direct damage to the tubules, occurs when direct damage to the kidneys causes a sudden loss in kidney function in the presence of ischemic or toxic insult. Sa post-renal, simple lang, may obstruction. Ganun lang. Okay? Okay. Sa mga na-hospital, very common ang paggamit ng ating mga contrast medium because they are needed in the diagnostic, lalo na in identifying some specific diseases in CT scan. That's why kailangan meron siyang contrast. But in return, there are some contrasts that are nephrotoxic. That's why we have what we call contrast-induced nephropathy. No? Acute renal dysfunction is diagnosed following intravascular administration of contrast agents. And usually, ito yung common cause nila, yung acute tubular nephritis. And toxic naman ang mga, there are some naman na less toxic. We have iodinated contrast agents. Okay. Ito din yung mga combination of factors na nag-occur in the development of nephropathy from contrast. Kakaroon ng hypoxia in the renal outer medulla of the kidney, some cytotoxic damage to the tubules, and transient tubule obstruction with precipitated contrast media. That is why I put this slide because some of you may experience yung if the patient is for CT scan, usually ang ginagawa ng nephrologist, bibigay ng acetylcysteine intravenous administration. And aside from that, sodium bicarbonate drip, no? To prepare for possible nephritis or nephropathy caused by contrast. Okay? There are some studies na sinasabi na there is no correlation or there is no parang high value na they will prevent AKI, pero there are some also studies na they show benefit the administration of acetylcysteine, lalo ng acetylcysteine in the patients who are going to undergo CT scan with contrast. Okay? May questions po ba so far? Sorry medyo mabilis. Questions po ba in AKI? Okay. So these are some of the signs and symptoms of AKI. Decreased urine frequency, anuric, or decrease in urine output or no urine output, hematuria, electrolyte imbalance, fluid retention, elevated serum creatinine, and of course, a decrease in GFR or decrease in creatinine clearance. Let's go to the phases. We have 4 phases. We have the onset phase, oliguric phase, diuretic phase, and the recovery phase. Again, since they are acute kidney injury, pwedeng makarecover ng ating mga pasyente dyan. Onset phase naman triggered by blood or fluid loss. Or ito yung tinatawag natin kanina na volume depletion. That's the onset phase. Pwede rin from burns. And if the patient is meron siyang diabetes insipidus, no? Wiwi ng wiwi. Okay. Symptoms siya is it's only subtle. And then the duration naman can occur from hours to days. No? Right after the onset phase, ito na. oliguric phase, which is one of the main phase that describes an AKI. No? Features niya, a urine output less than 400 ml a day, unable to excrete metabolic waste, meron ng electrolyte imbalance, presence of acidosis, and fluid overload or congestion. Symptoms are nausea and vomiting, edema, pwede magkaroon ng cardiac arrhythmia because of electrolyte imbalance, CHF because of fluid overload, drowsiness because unable to excrete ammonia, which can also contribute to encephalopathy, confusion, and coma. The duration is usually from 1 to 3 weeks, no? And yung manifestation niya is a decrease in GFR, increase in blood urea nitrogen and serum creatinine, electrolyte imbalance, pwede mataas ang potassium, mababa ang sodium, increase in fluid, edema, and causes metabolic acidosis. So, dito pumapasok yung mga ICU patient natin. So, meaning, if they are, those symptoms are present, meaning ang patient natin is oliguric. Okay, diuretic phase. Diuretic phase, meaning nakakawiwi na ang pasyente, no? So, meaning, it occurs when AKI is corrected. So, meron na tayong increase in urine output, 1,000 ml per day or 1 liter per day, possible electrolyte depletion, and increase in water excretion. And the GFR will start to improve. Okay? And the symptoms niya, urine output pwedeng tumaas from 4 to 5 liters per day, no? It is because of pag-administer din ng diuretics dito sa phase ng AKI. Can cause also postural hypotension, tachycardia, improved mental alertness, weight loss, and dehydration. Duration naman na to is 1 to 2 weeks, and the management usually supplements and IV fluids. Recovery phase, normalization na tayo dito ng fluid and electrolyte balance. And some patients are left some renal dysfunction, meaning hindi na ganun, may siya sequelae, meron siyang at some point meron part of the kidney that is not working properly. The GFR returns to normal or increase yung GFR niya. Symptoms, meron na tayong decrease in edema, and the duration is usually in 3 to 12 months. Tagal, no? Okay, so these are the monitoring parameters that when we are checking or when we know if the patient is undergoing AKI, ito ang ating mga parameters that we should be able to identify or we should be able to check as well. Ano yung fluid in and out niya or the fluid INO? Yung mga nurse kino-compute pa yan kung may negative ba siya or positive yung INO niya. Patient weight as well. Patient weight kasi this can be helpful in identification of edema. No? Baka bigla siyang bumigat ng ganito kabigat. No? That's why almost every day wini-weigh yung mga pasyente na at risk for AKI. Hemodynamics, nag-normalize na ba yung BP, yung heart rate, and na-achieve na ba yung mean arterial pressure na usually 65 mm per H per mercury. Lab values, serum electrolytes like sodium, potassium, chloride, calcium, phosphate, and magnesium. BUN and serum creatinine. The GFR, urinalysis naman to check din as well of the presence of infection din, the urine, the creatinine clearance din. And if lalo na if the AKI is post-renal. No? Okay, CKD, AKI versus CKD, ito lang pinapakita. For example, this is a patient na may sepsis. No? Sepsis-associated AKI, that's SA-AKI, yung sinasabi niya. If more than 90 days na wala ng recovery from the sepsis-associated acute kidney disease, pwede mag-progress into CKD or an end-stage renal disease. Okay? So, more than 90 days na hindi ma-treat ang AKI or walang development, walang recovery, walang improvement in terms of GFR, walang improvement in terms of serum creatinine, it can lead to chronic kidney disease. Okay, so ito naman ng stages, yun, more than 90 days, pwede maging CKD. Okay? Pag 7 to 90 days, acute kidney disease na ang tawag, hindi na AKI. Kahit anong ginawa pa, kinorek na through dialysis, continuous renal replacement therapy, okay? So wala pa din, dun na. It may progress to CKD. Pero hindi siya pwede mag-start kagad na CKD. Diyan muna yung, dun siya muna mag-start. AKI to AKD to CKD. Okay. Now, ito, importante nito for us pharmacists. Notable drugs in AKI, or which are some drugs that we need to be maging alert tayo when it comes to these drugs. No? Polymyxins. Polymyxins are one of the last line of antibiotic that are used in the hospital setting. No? Because of the severity of the resistance nowadays, na-revive ang mga polymyxins from the grave, no? Kasi these are toxic no? Specifically nephrotoxic drugs that are yun nga, very nephrotoxic in terms of their side effects. Pero yun nga, because of the emergence of resistance ngayon, they are being used nowadays. In Philippines, we have two polymyxins, polymyxin B and polymyxin E. Si colistin is also known as polymyxin E, no? Egg. Usually ngayon nowadays they are primarily used for infections due to MDR or multi-drug resistant organisms like carbapenem-resistant bacteria like E. coli, usually mga E. coli, Klebsiella pneumoniae, and some Enterobacter species. Pseudomonas aeruginosa, Acinetobacter baumannii as well. No? Yun yung mga, if you check the organisms, these are gram-negative. No? Ito yung mga malalang gram-negative infection na kinakatakutan natin sa hospital. So, if nakita nyo, meron ganyan yung culture ng ating pasyente, it can be a MDR, yung organism niya. That is why, usually, yun nga, these are gram-negatives, no? So, polymyxin have a narrow antibacterial spectrum, limited to a subset of gram-negative bacilli. Okay? Colistin, colistin sulfate, or here in the Philippines, mas common si colistin methate sodium, si CMS. Okay? So, the most important side effect of the IV polymyxin yun nga, is nephrotoxic and neurotoxic as well. Okay. Nephrotoxicity of polymyxins. If the patient is prescribed with polymyxin, renal function should be closely monitored. And we need to check for possible yun nga, hematuria, proteinuria, oliguria, acute renal failure to acute tubular necrosis, which can be irreversible ang acute tubular necrosis, which can lead to CKD. Si colistin, it should be adjusted for renal impairment or renal impaired na patients. Kay polymyxin B, renal dose adjustment is likely unnecessary. Yun yung difference nila. Okay? Okay, what is the, when does a clinician select polymyxin B versus colistin? Ang maganda kasi kay polymyxin B, it is administered as an active agent na. But si colistin, it is a prodrug when it is administered. So, meaning, it will be, kailangan pa niya ma-convert to be an active agent. Okay? Ang maganda rin kay polymyxin B, it is not affected by renal function. And it has been associated with lower rates of nephrotoxicity compared with colistin. Okay? It is because polymyxin B is extrarenally clear and yung urinary concentration niya are low. In contrast with colistin naman, it has a high urinary levels. And but it is because of its high urinary levels, it is preferred for UTI or complicated UTI, no? For multi-drug resistant E. coli usually. Okay. There are some studies, no, that some suggest that colistin is associated with higher rate of nephrotoxicity than polymyxin B. Okay, yun lang ang sinasabi dyan. And in most cases, the renal failure was reversible. Okay, So dito sa study nila, only one patient developed an ESRD or end-stage renal disease. Next one, of course, very common, vancomycin. As we all know, vancomycin is for patient na meron proven invasive gram-positive infection including MRSA. Si vancomycin kasi ang primary route of elimination niya is renal excretion. And yung renal excretion niya, unchanged. No? That's why it's nephrotoxic. Ang mechanism of toxicity niya in the nephrons is the apoptosis induced by accumulation of drug in the proximal tubular epithelial cells. So, doon kumakapit si vancomycin. Ang important kay vancomycin, yung serum creatinine niya should be monitored every 2 to 3 days to check for possible nephrotoxicity. Ako first hand experience with vancomycin, talagang nephrotoxic siya. No? We have patients na nagkaroon talaga ng rise in serum creatinine just right after 2 days of vancomycin therapy. Doon na tayo pwede mag-suggest ng decrease in dose. Usually, vancomycin is given with other antibiotic, lalo na for critically ill patients or sepsis. Usually, kinocombine siya with, for example, beta-lactams. Kailangan natin ng broad coverage, no? For example, against gram-neg, kasi we all know vancomycin is more potent with gram-positive, lalo na for MRSA. The recommendation is to select an hydrophilic agents like cephalosporin rather than hydrophobic agent, piptazo, to reduce the likelihood of nephrotoxicity compared with piptazo. There are some studies kasi na evaluating the combination therapy with vancomycin and cephalosporins, mas lower yung potential niya for nephrotoxicity compared with some hydrophobic agent na si piperacillin tazobactam. Okay? Management. The first most important one is in the management of AKI, we need to determine the etiology. Saan ba kailangan natin i-treat? Baka pre-renal yan, baka severity of CHF, shadow severe CHF congestion, naapektuhan na yung perfusion ng kidney, no? Okay? In pre-renal nga, or hemodynamic AKI, fluid replacement usually and hemodynamic monitoring is the key in reversing the injury. Normal saline is preferred fluid for replacement since sodium chloride loading reduces tubuloglomerular feedback and pre-renal injury. There is no vasopressor of choice for pre-renal AKI. And if drug-induced, dapat, syempre, magkaroon ng discontinuation of the offending drug. For non-pharmacological therapies, of course, we initiate fluid and electrolyte management, avoid the use of nephrotoxins. Ito makikita nyo in the hospital na if lalo if nag-AKI yung pasyente, lalagay ng nephrologist siya, no COX and NSAIDs, please. Ganun siya sa orders niya. Okay? Because of a risk of hyperkalemia for NSAIDs and ACE and ARBs din, no? Okay? And low protein diet para sa BUN and creatinine as well. Okay, in the severe AKI, renal replacement therapy such as hemodialysis and peritoneal dialysis is indicated. They are indicated hemodialysis or CRR or in general, hemodialysis is indicated pag meron ng ganito yung pasyente. Refractory hyperkalemia, volume overload despite some drugs, metabolic acidosis, uremic encephalopathy, and some removal of certain toxins. Okay? Yun na yung kailangan. Kailangan na mag-hemodialysis if these are present. Okay. Huwag na natin to. Okay. Si CRRT or the continuous renal replacement therapy is used almost exclusively for AKI. Si CRRT or the continuous renal replacement therapy, tuloy-tuloy yun. Usually 24 hours. Gumagalaw yun, RRT. No? And ginagamit yun nga usually for AKI talaga. And there are doses, drug doses, mag-iiba ang dosing ng mga drugs, specifically antibiotics, kapag ang pasyente ay naka-continuous renal replacement therapy or dialysis. Okay. Ang usual pharmacological therapies for hyperkalemia ay V-loop diuretics, no? Pwede. Si insulin and glucose as well. For metabolic acidosis, the administration of sodium bicarbonate, the administration of NAC or acetylcysteine. Ito yung sinasabi ko yung pre-contrast. Some studies as well, sabi nila, ascorbic acid intravenously, pwede rin, post-procedure. Okay? Okay. There, si metolazone, if you're familiar with metolazone, is a common thiazide-like diuretic. It is used in patients with AKI because unlike other thiazides, it produces effective diuresis kahit yung GFR niya is less than 20 ml per minute. Ganun siya kaganda, si metolazone. Okay. Ito naman, how about drug dosing in AKI? Ito yung, lalo yung mga antibiotics. So in AKI, is associated not only with reduced renal clearance and renal metabolism of drugs, but also with other impairments such as changes in absorption, hepatic metabolism, plasma protein binding is affected as well, and drug distribution. For critically ill patients, drug absorption may be impaired because of decreased GI motility. Okay? That's why pwede magkaroon ng residual, lalo na sa patient na naka-NGT, nagkakaroon ng residual sa kanilang tube, no? Kasi mabagal ang GI motility or decrease yung GI motility. Patient naman with sepsis may be receiving vasopressors, which may reduce gut perfusion naman and altering the bioavailability of orally administered drugs. That is why usually for if meron IV form yung drug, mas preferred sila for patients who are critically ill and may sepsis. Okay. In AKI, affected din ang volume of distribution of drugs because there's a presence of changes in the total body water and distribution of body water. And this will affect the volume distribution of hydrophilic drugs such as aminoglycosides, beta-lactams, and glycopeptides na vancomycin. That is why importante din ang therapeutic drug monitor if available in the institution. Protein binding as well is also altered in AKI. A decrease in synthesis of proteins such as albumin in critical illness can elevate the free fraction of drugs, leading to toxicity. So, pwede rin na dito rin magiging mas prone ng ating mga drug interactions if merong AKI because of decrease of protein binding. Okay, so last slide. So what are the possible pharmacy intervention in AKI? The administration of loading dose does not require adjustment in AKI. Remember that. Except for narrow therapeutic index drug like digoxin. So, ang importante dito, lalo na if a patient is septic or under septic shock, kailangan siya ma-administer talaga ng loading dose. Kahit gano'n pa kataas yan. Walang adjustment in the loading dose sa AKI. No? So, the identification of nephrotoxic medication, and we can also apply some appropriate interventions like renal dose adjustment. Again, for antibiotic, the recommended talaga is Sanford, no? A guide to antimicrobials, because it's lagi siyang ina-update. Longer infusion time as well, no? For antibiotics, it can also help the management of or lessen the severity of nephrotoxicity. And therapeutic alternative if also applicable. Lastly, we should be able to identify dialysable medications. How do we identify if the medication is dialysable? No? We can check for the drug inserts, or much better if you have renal drug handbook. Okay? For antimicrobials, much better if we have, ayun nga, Sanford. Pero here are some of the example na common na ginagamit in the practice. Meropenem. For example, meropenem is dialysable. Therefore, in patients undergoing hemodialysis, the dose should be 500 milligrams U24 administered every after hemodialysis. Magkaiba to ha. Ang CRRT, hemodialysis kasi usually may duration yan. 4 hours, 6 hours lang, 8 hours. For CRRT, it's continuous for 24 hours. Pwede pa mag 48 hours. Meropenem should be administered 1 gram IV Q12. Mataas ang dose niya for CRRT kasi continuous yung pag niya, renal replacement niya. One more example, amikacin is also dialysable. So, ang usual dosing niya is amikacin 500 milligrams every 24 hours. And if the patient is undergoing dialysis or meron siyang dialysis in that day, dapat magkaroon tayo ng additional supplemental dose. Should be given 2/3 of the original dose. Okay? Those are some of the examples of antimicrobials na dialysable. Pero kung usually, ang technique dyan, pag once a day lang siya, post-dialysis lang talaga siya na-administer. Okay? Okay, that's my last slide. Meron po ba tayong katanungan, questions for AKI? Or do you, anything you would like to add for AKI? Meron po ba? Wala. Okay. Sorry for the lengthy discussion. Medyo mahaba lang talaga yung topic na yan. More questions, class Basta pag if you have questions, you can just always, pwede naman i-PM anytime sa Canva Syntax or sa Messenger para mas faster po yung response natin. So, if you don't have any more questions, so I'll dismiss you tonight. Thank you guys for your time again. Thank you for listening. Thank you for giving 1 hour of your time. I'll see you guys again next week. Have a good day. Thank you. Have a good weekend as well. Thank you guys.
Thank you, Doc.
And nice meeting all of you. Mga kakamit ko lang with regards their work. No? Thank you very much. Bye-bye.